Problems with some of the batteries and so if yours doesn't work, we'll get the ones around that. Yeah, it's going to work pretty good. I'm probably doing sort of like a moderation.
Okay, everybody, we're going to get started. Can everyone in the back hear me okay?
Yes.
I know the people in the front are like, take it down a notch. All right, so hello everybody. Welcome to Inspire Carnegie Hill. We are super thrilled that you're all here today. We're excited to present another healthcare focused topic. And this particular topic has a significant amount of interest and fascination. And so today what we're going to do is we're going to cover a wide swath of subtopics related to the use of medical marijuana, also known as medical cannabis, which is actually the technical term that we want to be using, medical cannabis, specifically in the population of older adults. And we're defining that older adult category as people generally 55 or older. And we are joined today by a panel of distinguished experts who I will introduce to you in just a moment. Each of them come with different specialties and different perspectives, and we hope that together we'll be able to give you all a very comprehensive, honest, and holistic overview of the pros and the cons, the risks and the benefits, and the realities and the myths of medical cannabis use in this particular population. One of our panelists will arrive shortly. She's busy in another part of the building orienting some of our clinical staff. I'm your host. My name is Brian Geiser. I'm a board-certified psychiatric nurse practitioner with 25 years of experience in clinical, academic, and leadership settings. I serve now as the Chief Clinical Officer for Inspire, and I'm the Vice President of Clinical Innovation and Population Health for Inspire's parent company, Maplewood Senior Living. I'm joined today by this panel of clinical colleagues here, and I would like to introduce them to you, starting with Sang Choi. Sang is a registered pharmacist, and she's the dispensary director of the downstate region for ETAN, correct? ETAN, okay, ETAN, which is a medical cannabis dispensary pharmacy. Dr. Ken Weinberg, medical doctor. He's a physician, he's the chief medical officer at Cannabis Doctors of New York, and he is the leading medical marijuana physician in New York City. So this is Ken. It's self-proclaimed, or I'll call you that. And next to Ken is Dennis Tarrant, DNP. He's an award-winning, board-certified, doctorally prepared nurse practitioner specializing in adult health. Dennis is the founder and owner of Manhattan House Calls, New York City's largest nurse practitioner house calls practice. And he serves also as one of Inspire's in-house primary care providers. And he provides concierge-style primary care to our residents here in the building, in addition to other primary care clinicians, one of which is here in the audience with us. Dr. Rosen, raise your hand, there he is. So we have several amazing primary care practitioners who come to Inspire to take care of our residents, and we have two of them in the audience, one in the audience and one on the panel today. The last person who will join us shortly is Donna Maloney. Donna is a registered nurse. She's been practicing for over 29 years. Her background includes working in the emergency department, intensive care units, and in home health care. She has a PhD in education, and she specializes, and there she is. Donna is the queen of multitasking. So anyway, she has a PhD in education with a specialty in nursing. She's a clinical adjunct professor at Pace University and York College, and she currently serves as the senior director of integrated care here at Inspire Carnegie Hill. which among many other things means that she's in charge of the nursing staff and all of the care staff in this building. So with that, I'm going to kind of kick the discussion off here just by giving a little background on medical cannabis. And please correct me if I'm wrong about this, but you guys know better than me, but in 2014, the state of New York legalized medical marijuana usage by registered patients under the Compassionate Care Act. Between 2016 and 2018, legal medicinal uses were expanded several times to include treating conditions like chronic pain, PTSD, and therapy for treating opioid addiction. On March 31st of 2021, cannabis was legalized for recreational and medicinal use in the state of New York. So adults age 21 or older are allowed to possess up to 3 ounces of cannabis, or 0.85 ounces. We're having battery problems. There you go. Sierra, can you change this one? Okay. People can have up to 0.85, go ahead, ounces of, concentrated cannabis. Adults 21 and older are allowed to possess up to 5 pounds individually in their homes. In addition, that's not right? That's what I got right off.
Anything seems like a lot.
Well, this is what I got right off of one of the official websites here, so correct me if I'm wrong. That's why we have the experts up here. Basically, in recent years, interest and use of medical cannabis is growing substantially here in the United States and in many other countries. The regulations on its use vary among different states and different countries, affecting the medical practice and experience of patients. Current public opinion is that cannabis has the therapeutic potential to treat and cure a long list of diseases, but there's a large gap between that opinion and the current evidence in the medical literature. Another common opinion is that medical cannabis is mainly used by young adults. This is not true. Use by older adults is increasing, and studies show variable prevalence ranging from about 7% of the older adult population to about 1/3 of the adult population, depending on the country. Recreational use of cannabis by older adults is also increasing substantially, especially here in the United States. Okay, so with that said, we're going to kick off the panel discussion. I'm going to be the moderator. I'm going to pose a variety of questions and different topics related to medical marijuana to the panel. And then we're going to have lots of banter and question and answer from the audience as well, because I know that you all probably have lots of questions yourselves about the topic. So when I was thinking about the different types of questions you all might have in the audience, the big question for me really comes down to this. Should I consider taking medical marijuana, or should my loved one consider taking it? And if so, what does that look like for me? What does that even mean? So this is a very broad question, but it's an important one because we have lots of folks in the audience who probably contemplated taking medical marijuana for a variety of things. And we certainly may even have people in the audience who take medical marijuana for a variety of things. So we're here to talk about that. I'm going to put some people here on the spot. I'm going to put Dr. Weinberg on the spot, since he's the medical marijuana physician here in the room. So the question, Dr. Weinberg, is if I'm 65 or 70 years old and I have a variety of chronic conditions that I'm managing, and I've heard from friends that medical marijuana is this big, interesting, perhaps cure-all to all of my ailments, what do I do? Where do I go? And what's that experience look like for me?
Right, so you talked to me or one of my many colleagues who are at least as expert as I am in New York about it. I think the thing that's most important to realize is that it's not one size fits all. Not everybody responds to it. And there's always a certain amount of trial and error. When I started, I thought, okay, somebody has Crohn's disease, That's an inflammatory process. CBD is a great anti-inflammatory, do that. And in many ways, that's true. But I have a number of patients with Crohn's who, when they have a flare, they'll use a high THC product. And I just started saying, you know, you really need to take your time. It does, I mean, look, you know, without getting into it at this moment, this has been around for at least 5,000 years. And you go across all the different cultures in the East and in the West, it's been used. And it was only, I think, again, this is another conversation, but it was demonized in the 30s. It was part of the United States Pharmacopoeia until 1937. That meant that it was a drug, or it was part of drugs that were used across the country for a variety of things. And I think now we are fortunately getting out of it, but, and again, this is a different conversation. The fact that Richard Nixon decided to make it a Schedule I narcotic in 1970 has just hampered our ability to really do anything, to get that hard data. And it's a conundrum, because a lot of physicians that I work with will say, well, there's no data, there's no evidence. But yes, because, you know, it's hard to get evidence on a Schedule I narcotic drug. And so we keep going around and around, and we'll talk about that, but you know, that's really a big issue.
So you mentioned a lot there, and I want to unpack that a little bit. You're referring to medical marijuana as a Schedule I narcotic drug. What does that mean?
When the DEA started in 1970, they made Schedule I something that has no medical benefit and high risk of abuse. And what they have in there, apart from heroin, is psychedelics and marijuana. And again, it was, you know, without getting into a whole thing on Nixon, he thought that it should be illegal, and he had a Schaefer commission, the guy who was the governor of Pennsylvania, said to him, no, we should make it legal. And they went the opposite way. So it's been a Schedule I narcotic. And I'm sure Dennis has a Schedule II. I can prescribe cocaine for people. I can prescribe oxycodone for people. I can't prescribe marijuana for people, because I have a Schedule II license, but not a Schedule I license. If that
right. So
sense.
you're saying that, as an example, heroin is a Schedule I narcotic, right? Can you pass the mic to Sang, because this is an interesting thing for Sang, because she deals with it all the time as a pharmacist. Can you explain the schedule and how that works for the audience? So there's Schedule I through 5, is it?
Right, so there's Schedule 1 through 5. As Dr. Weinberg mentioned, Schedule 1, no medical benefit and highly addictive. And then just kind of gets a little less addictive, but still, you know, very, very potent and very strong. So that's why these schedules, like let's say a cough medicine with codeine in it, is Schedule 5. It's still could be addictive, but it's not as detrimental as, let's say, like hydromorphone or, you know, Percocet. So, so they're based on sort of their addictability, I guess, and the harm that it causes.
Okay. So currently, under federal law, DEA law, medical marijuana is still a Schedule I narcotic, correct?
Yes.
Okay. And it's akin to heroin in that sense, which is sort of laughable, really. So let's think about that. So there's this history that we're dealing with medical cannabis, that it was politicized, and there was racial issues and all kinds of problems with how marijuana was treated in this country all the way back to the 30s and maybe before that. So that's one thing that's interesting. The clinicians in this room, including myself and you guys up here who can prescribe, we can prescribe Schedule II through Schedule V, correct? And we're licensed to do that. How is it possible then to prescribe medical marijuana if it's a Schedule I narcotic?
Okay, this is when you go see someone like Dr. Weinberg.
Yeah, tell us how that works.
No, and Sang will talk to this too if she needs to, but basically there's a workaround, and I think all the states have similar kinds of workarounds. So I am actually recommending, when somebody comes to me, I write a recommendation, and then they go to someone like Sang, and she actually prescribes it. So that's really the workaround.
You can't call it a prescription.
take them.
You can't call it a prescription. It's called a certification or a recommendation because it's not legal, federally legal, so.
So this is interesting. So this is different than any other prescription medication, because what I hear you saying is that the clinician, the prescriber, we think is a prescriber, is not really the prescriber. You're really certifying somebody for the program, correct?
And making a recommendation.
Making a recommendation that medical marijuana might be something that would be clinically effective or appropriate for this patient. And you're certifying that that's the case, right? Then that allows the patient to go get a medical marijuana card, right? Then that card allows them to go to the dispensary pharmacy where they meet with somebody like Sang, who's a pharmacist, and they sit down and they talk about what would be best for me given my situation. So in many ways, Sang is a very important, critical element to how medical marijuana is dispensed and prescribed, right? The pharmacists in this case are actually doing a lot of the clinical work here, which is different than every other medication that I know of.
I will say that I've learned so much from Sang over the years, because she's there every day seeing patients and seeing what's happening on such a regular basis.
So let's go through a scenario. I'm a resident here. I live here, and Dennis is my primary care provider, which could very well be the case for people in this room. All right. So Dennis and I work together on managing my medical conditions. I have some chronic pain that's not well managed. I've taken Tylenol, I've taken ibuprofen, I've taken Aleve, it's not working. Dennis, as a clinician, has to think, well, what next can I do to help Brian deal with his chronic pain? And one of the options, of course, are opioid narcotic medications, which come with their own set of major problems. Another option, perhaps, could be medical marijuana, right? So you're the primary care provider, Dennis. What's going through your mind, and how do you help Brian deal with his chronic pain?
I do see some familiar faces here. No, actually, it's a great question, and I like the way that you sort of pose that scenario, because that's the most common scenario that I come across when people have different issues, either be it pain, depression. Usually I'll be the one to sort of bring it up. And I've been doing this for 25 years. And over the last 5 years, when I start the discussion now, and I'll say, have you ever considered medical cannabis? They'll tell me, oh yes, what do you know about it? And where it used to be 10 years ago, Dennis, what are you talking about? We're both gonna get arrested. Because it's just the way that we've all been trained in medical school or in nurse practitioner school. But now it's not becoming the last ditch effort any longer. That for a long time I've had to give medications that I was not thrilled about giving. OxyContin, fentanyl, oxycodone, Percocet. These medications that once Tylenol, Advil, Tramadol run their course, but the patient is still in pain, the next step was to go into the opioid class, which in and of itself, when it's done responsibly, is fine. But now we can have the discussion about cannabis and using medical marijuana as a means of pain control. And often when I talk to patients about it, they're very, very open to that, to say, yeah, let's have that discussion, let's talk about it. And it's accessible. And then that's when I'll talk to Dr. Weinberg to say, I've got a patient of mine that I think would be a really good fit for you and your program to work with this prior to going into the next step of opioids, which in and of itself is not the criminal here. But sometimes if the medical cannabis doesn't work, okay, we've gone that route, it didn't work, and maybe we do need to go ahead. But I do think that it is a conversation worth having with your provider, with me. And so far it's worked out quite well. I've had a lot of patients who don't get relief on the first ditch effort, but by working with Sang and with Dr. Weinberg, we do see some pretty good results across the spectrum of different ailments, from IBS, irritable bowel syndrome, pain, depression, that kind of thing. And so generally I'll bring it up, and then the patient who I'm talking to generally is very, very inquisitive about it and has a lot of questions about it. There are federal issues that it's all worked around through New York, But because, again, as we were mentioning, it being a federal crime, Medicare doesn't recognize it as a reimbursable service because Medicare says, hey, we're a federal program. We can't say that this is okay, even though half the people in the Medicare office probably are using it. But that being said, you know, it's come up a lot, and I suspect going forward, it's such a great anti-inflammatory property that I'll be using it and referring a lot more going ahead.
Okay, so one possible journey is a patient meets with their primary care provider, like Dennis, and Dennis says, we've gone through a variety of different treatment options. Let's think about medical marijuana as an option. Would you be interested in that? Sure, I can explore that. And then you refer to Dr. Weinberg, and then Dr. Weinberg does his thing, does an evaluation of the patient, determines that medical marijuana may be useful for chronic pain management in this case. Then you certify the patient. The patient then goes on to a website or something and gets their medical marijuana registration card. Is that how it works?
Yeah, they're licensed, yeah.
So once Dr. Weinberg certifies a patient, the patient or the caregiver will have to log on to the OCM website and register for a card. So
Okay, and OCM stands for?
the Office of Cannabis Management.
Which is regulated by the Department of Health in New York State.
Yeah, I mean it was the Department of Health, and then they
Moved it.
they moved it to the OCM. So yeah, it is a regulatory body in New York State that will that kind of takes care of this whole medical marijuana program.
So New York State, from the top, the governor's office all the way down, recognizes medical cannabis as a viable alternative treatment, which is legal in the state of New York. Just to be clear.
And I'll just mention, because what happened, everything was there's a whole hemp program that was under the Department of Agriculture, and then the medical marijuana program, which was under the Department of Health. When they legalized adult use, they put everybody together into the Office of Cannabis Management. So that's really the supervising body, just so it's clear. But that really happened when they brought in adult use, and they're the ones who are doing adult use also, who are involved with that.
So Brian,
Yeah, I want to pass the mic to Donna. Can we just pass it over? Yeah, you need a mic. You're in the back.
always the one.
Yeah, go ahead.
So I want us to go back, right? Because you spoke about one avenue, right, of how we're going to do this. The residents meet with their, primary care providers. But being that they're in the building, right, you have to also identify our part in that, right? And I see us as an interdisciplinary team, right, in our collaborative efforts to maintain the health and wellness of the residents in the building. But with that being seen, our staff is seeing maybe the pain, the discomfort, whatever other means of utilizing it in our memory care population, right? In Oceana for agitation, behavioral disturbances, those type of things. But I just want to identify the collaboration on our part, right? Because the most important thing is that we have tried things along the way and not the conversation that is just coming out right to the residents. Let's go straight to cannabis, right? We have to make sure, because that's something the Department of Health looks at when they come into the building, to see that we've tried A, we've tried B, we've tried C, and not just having a conversation to straight say, we're putting this resident on cannabis. So that involves having the discussions with us and, us meeting and, meeting with the residents and giving them options. I think from a clinical standpoint and the clinical team in the building, that's also another avenue. They may be coming to us first and then us coming to you all, but if they do directly come to you, keeping us in that collaboration to work together for the resident.
Yeah, and I think Donna makes an interesting point, which, and we sort of didn't get there on the patient journey yet because we went from primary care to cannabis, right? And then what happens next? Okay, so the patient now has been certified to be in the program and has their card. Okay, great. Now what do you do? Well, if you're a resident of Inspire, what really should happen in that case is that communication goes right to the clinical team so that they also know that this is happening and they can help coordinate and manage that process. And then the patient gets to the dispensary and has a consultation with Sang and her team, to decide what might be the best formulation, what might be the best strain, and we'll talk about all what that means in a little bit, right? And then, so there's a clinical decision made on what should be done, and then an order has to go from, say, Dr. Weinberg over to our clinical team, and then the medication has to get over to the building, and then Donna's team has to get that medication and store it properly. So there's a lot of steps along the way for our residents who live in the building, who we're managing their medication. All right. Before we get too technical and too much into that whole process, I want to step back for a second because it struck me as both Dr. Weinberg and Sang were talking that these two clinicians spend 100% of their time now dealing with medical cannabis. But that wasn't always the case for them. So Dr. Weinberg is an emergency medicine doctor. He worked in emergency rooms and took care of people who were in critical condition. And he did that for most of his career. And then one day, many years ago, he decided to make the switch to cannabis. I'm fascinated, Dr. Weinberg. Why did you do that?
All right. So I have to go back. I was always interested in mind-body interactions, and I actually did a residency at LA County in internal medicine. And then my friend was the head of psychiatry at the Manhattan VA, and I came back to New York to do a fellowship in psychoneuroimmunology, which was really looking at mind-body interactions. I always was fascinated. I think this was in the 80s, and I think even more and more, we're all so much aware of how the mind and body do work together. Unfortunately, what happened is that I was doing a study to treat AIDS patients with acupuncture, and this was in 83 and 84. Signed up patients, you can imagine, in 83, everybody with AIDS, it was basically a death sentence. And when I said, well, do acupuncture on you, they said, great, mazel tov. I mean, there's no downside to it. Unfortunately, the head of medicine at the Manhattan VA didn't want the VA to be known as a place, in his words, that was using voodoo medicine. And so I quit. I could see I was not going to be able to get anywhere with this. And I started working in the ER at Bellevue under Louis Goldfrank, who's like one of the icons of emergency medicine. And all of a sudden, I became a board-certified emergency physician, but I was always interested in mind-body interactions still. And when the law went into effect, another emergency physician friend of mine said, this is becoming law. Are you interested in starting a company and working and seeing how this works? And I knew certainly from California and other places that there were definitely benefits, but I really had no idea of what the depth and breadth of benefits were. And what's interesting though is I feel like I've come full circle in a way, because I think the endocannabinoid system, and it's a whole other conversation, is very much involved in mind-body interactions. So here it is 35 or plus years later, and I'm sort of back to where I started.
Thanks, and that's a great story. And Sang, can you tell your story briefly? Like, how'd you end up here?
So I, as a pharmacist, I don't think, anybody growing up will, graduating school say, hey, when I grow up, I want to be a pharmacist, So I think maybe that happens now, but back then it did not. So, I wanted to keep it very interesting. I wanted to keep my work very interesting. So when I first graduated pharmacy school, I actually worked with HIV patients with very, very, very complicated drug regimens. So now it's about, maybe 2-3 tablets a day. When I graduated school in the 90s, it was about maybe 30-40 tablets. Like, this pill burden was like a lot, So what ends up happening is you become very good friends with your patients because you're really managing their medication care. So it's not just about medications. Because these medications are so strong and they work in a way, they cause all these side effects. So then you have to take medications for side effects. You're trying to help patients just manage, live their lives and have the best life possible, right? Obviously the quality of life is very, very important for everyone. So after that, I just started working in very interesting sort of fields in pharmacy. So fast forward maybe 15 years after that, I live in New Jersey, and I was walking my dogs in New Jersey, and I saw this sign that said medical marijuana passed in New Jersey. So this happened 2 years before it happened in New York. And I was fascinated and like weirded out a little bit because I thought it was a West Coast thing. I thought it only happened in California and Colorado. So the whole way back home, I started thinking about what is this? And just like many of you, and I'm sure the thought process has changed a lot in the last like 5-6 years. But I thought, well, this is strange. It just makes you high, right? It's so I came home, I started researching, I became like sort of obsessed with it, and realized, wow, just reading about the medical benefits, I was astounded, to be honest. So I thought, well, okay, so why don't I take a trip to Colorado, see what a dispensary is like? So in my head, I have all these thoughts about what it's gonna look like really seedy and weird people hanging out. But honestly, when I went in, it was like the most beautiful establishment, kind of like here, So that's when I started thinking, maybe there's something to this. So over after that, I just started researching and just learning as much as I could, and then I was given this opportunity to be on the application for the program. I actually work for a women-owned company, and 8 months later, we got the license. So that's my story.
Thank you. That's excellent. So let's talk about what are the things, the conditions that qualify someone to get a medical cannabis registration.
There have been updates to the medical marijuana program. So before, when the program first started, there were about 11 qualifying conditions. So the patients that Dr. Weinberg and I were seeing were just patients with severe disease or just conditions. Now, the qualifying conditions have gone away. So there are no qualifying conditions. So your practitioner, your doctor, nurse practitioner, is able to recommend that if they deem that you could benefit from the use of cannabis.
Interesting. Go ahead, Dennis.
What I've found is that when I'm seeing my patients at home, and again, we have about 600 patients that we follow in the city with a whole host of different chronic conditions, and everything from ALS to multiple sclerosis, to chronic pain, dementia, post-traumatic stress, depression, and a whole lot of different chronic conditions that as I see them, and sometimes as we're talking, it'll just sort of spark a light in my head to say, you know what, maybe we're going about this wrong, and maybe there are other options. And I found that when some of the patients that I've referred to for cannabis therapy, it's actually worked out quite well. But it does start at from what I found, it started at that primary care visit, when you're sort of discussing a whole lot of options or a whole lot of topics, and you start going over medications, and you start to realize, what is it you need, what don't you need, and is there another way that we can approach certain conditions for certain people that haven't been down that road before. I've had some patients referred for acupuncture, and it's worked out well, but they've never talked about it before. And these cannabis conversations that I'm having with patients about their chronic conditions of 30 years, 20 years, the first time they've had that conversation about medical cannabis is right there in the living room with me as we're talking. And I find that those conversations often start in primary care, and that's when the team gets on board. And I know for some residents in Inspire, we don't work in a funnel. I will hand it off to Dr. Weinberg, and then it will go into the Inspire team, and then the idea is that we want to benefit the wellness of all the residents here. But I find that a lot of the conversations will start with the primary care visit.
So, yeah, sure, Dennis.
So I want to go back to what you were saying, right? So you started out with 11 criteria, am I hearing that correctly? And now it's been broadened, right? 10, 11, okay. So now it's been broadened. So can you bring to the forefront, right? So that's your inclusion categories. What are exclusion categories, right? Because as we're in the building, right? And if it's the avenue of the resident is coming to us and having those conversations, I think we need to identify who meets the criteria or who doesn't meet the criteria.
pass the mic.
Come on, you gotta get another one.
I know, I'm the worst here. We need another mic up here.
You know, I think it's really an individual kind of thing. I don't think that I would say someone who has cardiovascular disease couldn't get it, or schizophrenia. You know, because what's been extraordinary to me is how often people do respond. And earlier on, I would be treating patients before they expanded the conditions, especially during the time of COVID. I would be treating patients, for example, for chronic pain or inflammatory bowel disease. And they would say, boy, you know, it's great for that, but my anxiety during COVID has been off the charts, and it really helps my anxiety, my depression. So I think, to answer your question, you know, I don't think that I would say there are specific exclusion criteria. I think it's really a patient-by-patient basis. And yes, there are, you know, I don't think it, whoops, okay. I think it's really a patient-by-patient basis. And again, I don't want to make it seem as if it's a panacea. It doesn't work for everybody. There are interactions. We have to be very careful, especially in an elderly population who have all of these underlying problems and are on so many different medications but I think I would not say there's specific exclusion criteria, if that makes sense.
Okay. So are there any drugs in particular that have drug interactions that we should identify that shouldn't be combined?
Yeah, so there are some drug interactions. You know, it does get metabolized by the liver, so it does affect, you know, the cytochrome P450 system as well. So there are definitely drugs that it will affect. So the biggest one is warfarin, and I don't know, you know, how many patients are on warfarin, but you know, obviously we have mechanisms and we have tests that we run on a regular basis. So if their INR was a little off or something, then you'd be able to adjust, you know, the warfarin content and things like that. So yeah, so there are definitely some drug interactions. Like nothing is really contraindicated per se. But obviously, like the first, you know, month or so, it really requires a lot of just kind of observations, you know. I think Dr. Weinberg and I are just so careful to dose, on how we dose. We have a certain protocol that, you know, we stay below 5 milligrams of anything, because we know that a starting dose of, let's say, THC or CBD is about that, 2.5 to 5. You know, we also consider a lot of other things. You know, we consider like balance issues, we consider memory issues. You know, there are a lot of considerations that we take. So that's why I think when, you know, your resident starts cannabis for the first time, the dosing is like very, very low. You know, very, very low. And the reason that we do that is because it's always go slow, go low, go slow. Because why max it out if you can accomplish the same thing with a very small dose? You know, especially, you know, avoiding some of those side effects as well. So I think, you know, we are very careful to really dose somebody just to make sure that they're okay with it, they're tolerating it well. You know, and it's nice that, you know, everyone here is so involved, because you will know like any tiny little change that a resident has, you will observe that and you will know that. So you'll say, oh, you know what, I don't think this is working. Well, okay, so they're on a low dose. Maybe we should increase that by a little bit. So I think we just take our time, and I always set expectations as well. I'll tell someone, you might not get anything from this, you know, according to the dose that you're on, but that's okay. It's trial and error. Let's see how it goes. I might have, you know, Dr. Weinberg and I might have to change the ratio, like increase the CBD or decrease the THC, or, you know, opposite. So, you know, but once you get there, you know, it's really nice. Once you get the pain relief that you need, once you get just whatever, you know, relief that you can get. And, you know, no one is saying use just cannabis. No one is saying that, you know. I would say majority of my patients that come into the dispensary, they're on medications, but maybe you want to lower some of the doses because of your pharmaceutical drugs, because maybe the side effects are sort of intolerable, you know. Maybe it makes you too tired, maybe makes you groggy, but maybe you want to go do something during the day. Maybe you want to like be awake and just living your daily life, you know, without the tiredness. So that's what we try to sort of manage for the patients that come in for medical marijuana. So And Dr. Weinberg is correct. It might not work for you because there are a lot of different factors in why it doesn't. There are some receptors issues, there's some, genomic issues, things like that. So there are a lot of different complicated factors.
Yeah, and I'm hearing a lot of different things here. This is really important. One of which I didn't even know, is that in the state of New York, there are no inclusion criteria any longer. They've been eliminated. It's basically if the clinician feels that you would benefit, they can recommend you for the program, and then you can go to the dispensary once you get your card, and you can talk it over with the pharmacist. That's very interesting. There's also clinically not necessarily exclusion criteria, meaning these 10 people with these conditions should not take it and cannot have it. So it's really a clinical decision that has to be made in collaboration with your medical team. And in the case of at Inspire, it would be your primary care provider. It would be Dr. Weinberg, it would be Sang, it would be our nursing team, all working together as an interdisciplinary group of clinicians helping you manage this new substance that you may be taking to address a variety of different ailments. I want to ask, speaking of ailments, what are the top, say, 5 things that you guys have seen as clinicians that it can be very effective for?
I think 70% of the patients at least are chronic pain. And then after that, autoimmune disease.
Such as?
Rheumatoid arthritis, scleroderma, lupus, fibromyalgia, what else? Ankylosing spondylitis. I mean, any of those autoimmune disease, multiple sclerosis is an autoimmune disease. And that was one of the things that struck me early on. The patients who I would see with autoimmune disease, regardless of what it was, just seemed to do so well, and remarkably well. And I think it's because of CBD, and we haven't talked about that, and I don't know if we'll have time, but it's all about the ratios of THC and CBD, which are the 2 predominant chemicals in the plant. But CBD especially is such an incredible anti-inflammatory medicine, and all of these autoimmune diseases, that it's inflammation is chronic, constantly going on, and that CBD really hits it.
So yeah, let's jump into that for a second, because if I'm sitting here and I have if I have a marijuana plant in front of me, right? You got, everyone recognizes what a marijuana plant looks like, and then there's these buds that come off the plant, right? And then you take the buds off and you use that part of the plant. But when you talk about CBD and THC, what does that mean, and what does it mean for the regular person who's taking this? Can somebody take just CBD and be okay without the THC? Tell us about THC and CBD.
The plant has probably 100 different cannabinoids, which are very, very similar structures. So there's CBC, CBG, THC, they all look very similar, and I won't bore anybody with what the structure looks like, but they're very similar, and yet each one of them has very different properties. In addition to that, anybody who's ever smelled marijuana knows that there are very distinctive smells, and those are from the terpenes. The terpenes are a very important part of it as well. And I think ultimately what I have come to realize is you want to get as close to the whole plant as possible, because they all work really strongly together. And again, we don't know if the THC is going to be better for you, for your energy, or the CBD might be. And also, there are plenty of patients who do just take CBD for pain, or for anxiety, or for sleep, and it works fine with them. Generally, I'd say there's something called the entourage effect, where you really want as many of the components of the plant as possible. But CBD, which you don't get it from your local bodega though, because the problem with cannabis is that it's a hyper accumulator. They actually used cannabis after Chernobyl to suck up all of the radiation in the soil. So that's what it does, and from the air. And so you really need, if you're getting something, if you go to Sang at a dispensary, it's been tested at the Wadsworth lab. There's no toxins, heavy metals, pesticides. But if you go into the local bodega, it's unclear what you're going to be getting.
So let's go back to the THC CBD ratios for a second. So maybe Sang can cover this. Why would I want to have more THC and less CBD, for example?
It's all different. So CBD, as Dr. Weinberg mentioned, is non-psychoactive, which means it doesn't make you feel unbalanced or ultimately doesn't give you that high, right? That we're a little bit wary of. So anti-inflammatory, reduces anxiety. It also helps to relax the muscles of the body. So it just kind of gives you a nice relaxation effect without the high. THC side effect is the psychoactivity that you may experience, like a high, right? But it also depends on the dose that you're taking. So starting with a small dose, while your body's adjusting, you might be able to tolerate it a lot better. So THC works in our body by working all along our pain pathways. Really kind of just sits on receptors in our brain, in our central nervous system. So it helps to kind of regulate pain that way, really excellent for neuropathy or nerve pain. In addition to that, THC helps you eat if you have a lack of appetite. It helps with sleep, it helps with anxiety. But again, this is all dose-based according to the person and their body and how they're made. So, someone might be able to handle a lot of that and some people don't. So it just depends. That's why we start somebody on a very small dose, kind of like a standard dose, just to see the effects of that. So it helps, and the reason that we put them together is because they're used differently. So during the day, you might not want to go so high in the THC because it's going to make you tired and drowsy. Could you have a little bit of that? Yeah. Because the thing that CBD does also, it mitigates some of the side effects of THC. So if it'll bring down some of the high of THC, that's why you put them together as well. So the ratio that I like a lot is called Armetto, which is the 2 parts of CBD to 1 part THC. The reason behind that is because, number one, having a lower amount of THC, you're still getting some of the benefits of THC, but you're getting higher in the CBD, which will bring down some of the side effects of THC. So I feel very comfortable, giving that to someone who's starting out for the first time. CBD with a little bit of THC, which is our 1 to 20, which means 1 part of THC to 20 parts of CBD, will take time for it to work a little bit. It'll probably take up to a week. And I think a lot of times what ends up happening is, someone will say, it's not working. It's not working for me. So I think adding that, a little bit higher level of THC is helpful because you'll start to know the effects like pretty much right away.
So when do you say you would stop, right?
Take it like this. They can't hear you in the back.
When do you say you would stop? You say maybe you need to add a little more. You add someone on, or you start someone on 1 to 3 drops, and then you end up giving them 3 to 7. At what point in time are you identifying that this is not working and this is not the drug for them? I keep forgetting to give you.
I think it's really going to be based on, the patient's results or what they're feeling or what the feedback is, right? And also like what you observe about what's happening after they've started medical marijuana. Again, it doesn't work for everyone, and one size does not fit all. So the dosing is all different. So that adds a little complication, I think, to what you guys do here, because it's not like a pharmaceutical drug. Here, take 1 meloxicam a day, right? Easy. But cannabis is one of those things where it takes time. So I know it's complicated because we're always changing doses on you.
Let me just, if I may. What I have learned over the 7 years I've been doing this is that the patients who do the best are the ones who have really taken their time. And it could be weeks, or I'll talk to a patient after a year and they'll say, it's been several months, but I have tried all these different products and now I know I wake up with anxiety, so I'm going to take this product. Oh, I'm having pain, I have this product. They wind up having a number of different products to use for the various things that happen. For some it works immediately, and others really, it can take quite a while, but I think you have to be open to it because the majority of patients will do well, and they'll really be able to find the sweet spot for the different ratios, the different forms of ingestion as well.
Right, that's another topic we have to talk about. So it sounds like it's not simple. So it's not like take this dose and this strain and see it in 30 days or 3 months. It could be a process. It could take some time to unfold. It could take many months to kind of get the right dosage and the right strain and the right formulation. And that's working with your medical team here to try to figure that out. You just have to be patient. I have a very good friend who has chronic conditions, including an autoimmune condition, and she's a nurse, and she takes medical marijuana, and she's figured it out. But it's taken a long time for her to figure out exactly what she should be taking when. And she does have multiple different products in the closet, and different ways of ingesting it. So I want to talk about that. What are the different ways of ingesting that the older adult population tends to use? And also for the Inspire population, we have to talk about the ways it can be ingested here in this setting, because there's certain things that we can't do in this setting, including smoking. So,
yeah, I can talk about it, and I'd like Sang to weigh in, because to me, there are 3 ways of approaching it, or 3 different ways of taking cannabis. One of them is the topicals, which are really good for a lot of patients, and I'm sure Sang has seen this, who have joint pain. And they rub it in the joints, and it's very, very helpful. It doesn't get absorbed, so you don't have to worry about having systemic effects. And then the other 2 ways of taking it, in my mind, are the rapid ways, which could be a vape, could be a spray, which Etane has, which I think is really good, which you spray in the mouth, under the tongue, or on the cheek, and drops. So those will come on in 15 minutes or so and last for a couple of hours. I often will tell people, especially not as much here, because working with Sang, I think she's been good with the other way of taking it, but I often will tell people on the outside, try the fast-acting products, because you can sort of work your way up, and you'll see if you're having, what kind of response you're having. And you can always go up a little bit. Nobody in 5,000 years that we know of has ever overdosed on cannabis, and I think that's an important thing to keep in mind. And then the other way of doing it are the edibles, whether it's gummies or powders, things like that, which can take an hour or so, but can last for many, many hours. And you might want to just talk about your products.
Yeah, so, I was thinking about what would be the easiest and sort of, what would be the easiest product, for everyone here. And I think that, something edible, like Dr. Weinberg said, so we do have like a little candy. It's in the high THC, but you could take it at nighttime to help you sleep a little bit better. I think capsules and maybe the spray is very nice. So the spray is like a mint-flavored spray that you just spray in your mouth. It takes about 30 to 45 minutes to work, and it works for about 4 to 6 hours. And then we have capsules. So once you get to a certain dose and we know that you can handle the content of THC, then the capsules are probably going to be the easiest just to add into the drug regimen, because that's just easy. It takes about an hour and a half to work, but it works for 8 hours, which means that you might only need to take like 2 capsules a day, which would simplify the drug regimen. So it does come in a vaporizer. It comes in the topical formulation. The reason the topical formulation works really well for muscle aches or joint pain is that our skin has the most amount of receptors that can accept cannabis to be utilized. So that's why it works beautifully. And the fact that it doesn't get into the bloodstream to make you high is actually a really nice way of using a product. So what I recommend is doing something orally and then maybe applying the lotion on the areas that you have the pain.
Dennis, go ahead.
Being in primary care and often being the gate, to open up the gate to cannabis, because a lot of folks, a lot of residents here or patients that I see out in the community, they don't know Dr. Weinberg. They don't know Etane. How are they going to get there? And often I'll kind of do the introduction, but what I find is that a lot of people, there's a lot of information that is misinformation. And they'll say, Dennis, I can't smoke this, so I didn't even bother thinking about doing it. I'm like, but you can do a cream. I can do a cream. What do you mean? Or is this in a pill form? And there's so many different options or so many different ways that this can be given that they didn't really even know that it was an option. And they'll say, yeah, then the barrage of questions will come. I say, listen, let me get you an appointment with Dr. Weinberg, and then they start talking about it, and then they'll use cream for their knee or whatever it might be. But I think there's a lot of misinformation, and when people will go to their providers who may not be very familiar with it, it gets poo-pooed very quickly to say, listen, you can't smoke this stuff, so don't even think about it. But they don't realize that there's a lot of different options and varieties and ways that this can be given. And then again, it's not a one-size-fits-all. It's not walking into a corner store and picking up a bag and start taking it. And I find, again, being in primary care, like most specialists, we're sort of the ones that guide people through the healthcare process. And so when patients of mine go to you guys and go to the pharmacy, and we're all on board here because all the pill bottles have my name on them. So I kind of want to make sure that everything is playing well together, and every pill can interact with another one, but that's no reason to not take something. You know, warfarin or Coumadin is renowned for not playing well with others, but that doesn't mean you can't do it. It means that you just need to keep a better eye on it. So often I think that the different forms that cannabis can be given is highly underutilized or highly unrecognized until you're sort of open to it.
Thank you. So I think what I want to do now is open up some questions to the audience. You guys probably have a lot of, your wheels are turning and you have a lot of questions. Lena, can I have somebody help with the mic running? Because I think in order to have the audience ask questions and people hear rather than us repeating.
I'll be your runner.
No, test. Okay, so if you have a question, please raise your hand.
Here goes
And speak right into the microphone if you could.
I have a batch of questions. I'm listening to this presentation and I'm finding several things that are very confusing. Number one, it seems as though the various products of cannabis are poorly defined and there's no seem to be pharmaceutical style determination on what cannabis product is in, how much of what is in which, and it seems to be very variable as to how much of what is in which, because it's not being manufactured by what we would used to think of as a pharmaceutical house.
Can I answer that?
Yes, that's a great point. Go ahead, Doug.
It's not true, and I'm sorry that has not come through, because what I like as a physician is that it's a medical program and it's precise and consistent. So if you go to Etain and you get a product that has 5 milligrams of THC and 5 milligrams of CBD, it's precise. That's exactly what you're getting. They have dosed it. I mean, Sang has told me that they're held to a higher standard than the pharmaceutical industry. And it's consistent. So if you have, let's say that you take that 5 milligram THC, 5 CBD product and you have X, Y, and Z benefits, you know every time you take that, you're going to get those benefits. And as a physician, that's very important to me. But it is a medical program. It's very tightly controlled.
So it's being manufactured in such a way is that you can be very clear about how much of what and how much of which product is in each medication that's being suggested. Is that
Absolutely,
correct?
absolutely. It's not
Okay,
like
because
going out and smoking a joint where you have no idea what you're getting.
All right, that's number one. Number two is my sense that the response is very unpredictable, that one assumes you're going to start with a low dose and hope that the symptom will be relieved, but then you vary the dose based upon what the response to each patient is, because the response to each patient seems to be so variable. Is that the case also?
Yes.
Yeah.
I think you said it accurately.
So I think you have to consider also pharmaceutical drugs are the same way, right? So you wouldn't start somebody on the highest dose, you would start them on the lower dose just to see, and then your doctor will say, hey, follow up with me in a month. I think there are real results that do occur. I try to manage side effects for our patients, right? Because there is also that stigma, social stigma of being so afraid of, cannabis that, I want to manage someone's expectations, right? So you might try multiple medications, multiple pharmaceutical medications, and then maybe on the third or fourth one, you figure out that's the one that works for you. So this is just plant-based medication. It's just not mass-produced like a pharmaceutical drug, but again, the testing for these products is so stringent that we are held to a higher standard than a regular pharmaceutical company. So we have to stay like 5% plus or minus, margin of error. So even drug companies are, they don't have to be that exact. So, I mean, they're exact, but we're just held to a little bit tighter standard. So these are tested. What we say is in there is not in there, we have to destroy the whole lot, okay? Cannabis extract is very, very expensive. It's, you get a plant this big, you grind it down, you put it through a machine, and you get like this much oil. So it's very, very expensive to produce. So that's why we try to get it right the first time. So it's very standardized, and it's very, very, it's very pure.
And it's also highly regulated, right? So
Highly, highly
My
regulated.
question about where is this being manufactured? It's not in a pharmaceutical house.
So we
Where
have.
is it manufactured?
So every dispensary here, there are about 10 companies up and running the medical program. Each one of those companies has 4 dispensaries across the state of New York, and we all have our own manufacturing facility. So our products are grown and manufactured in Chestertown, which is right by Lake George.
And you're saying that the regulation of the products at these manufacturing places is similar to a pharmaceutical house?
Yes, we're highly, highly regulated. Yeah.
All right, next question is, how do you supervise a patient response? What's the interval at which you will, do you see, who interviews the patient and makes a decision about what products are going to be used, and then how do you supervise that response and make a decision about whether the patient is getting a decent response or not a decent response?
So the decision is based on, my conversation with Dr. Weinberg. So Dr. Weinberg, you meet with the patient, right? Okay.
Yes,
Okay, and then you assess sort of what's happening, you have a conversation, and then you and I discuss what ratio the patient might want to start with. So, but then when I speak to you, when I consult you, I have the whole conversation again. I want to know what medications you're taking, I want to know what you're experiencing, what your issue is, what your condition is. Do you eat okay? Do you sleep okay? Where's your pain? What's happening? So I go through the whole thing again with the patient or the caregiver, and I explained every ratio. Like, this is what this does, this is what that does, these are the products that we have, and then I say, hey, where do you think we should start? What would be the most convenient for the patient?
Okay, I'm confused about how the patient is evaluated. Who does the initial evaluations?
I do the initial evaluation.
What's that?
I do the initial evaluation.
And then once you collaborate with whom before you
With the
make
nurses, well, we talk, I talk with Sang, I talk with the families, and the nurses have to be very involved in this also. They're seeing the patients every day. I am not. So,
But that's part of the response, the second part of your question, right? The symptomology that we are going to be assessing and observing here on site, right? Is it working? Is it not working? That's when we go back to, Dr. Weinberg, and him and Sam confer with that. Because if the resident was started on the lowest dose, 1 drop, then does the resident now need 3 drops? If it was once a day, do they now need twice a day, right? What drop in the morning, a drop in the evening, and I think we need to speak to that too. When you do the assessment, how are you identifying what form of cannabis they're gonna be getting or what is right for them? Is it the drops, is it the pills, right? We don't do the vape here, I haven't seen that, or is it a capsule? I think that's, information that they need also.
And I think, go ahead, Dennis, I think the primary care is involved.
Yeah,
as well.
Dr. Bolton, good to see you. And I'll tell you, I think when you ask the question of, I sort of ask who identifies the patient of who's going to get this, who doesn't get it. I think ultimately, for myself, my own practice, it's me. Meaning that the chain generally doesn't start until I see you and we have that discussion. And so, somebody, in this room that I would see, I would have that discussion already as to who would benefit, who wouldn't benefit from it. And usually I'll be bringing it up, or the patient brings it up to me. Going from there, when I give Dr. Weinberg a patient, I say, listen, Dr. Weinberg, I'd like to have you evaluate this patient because he or she has chronic pain. I'll send the whole chart over to him. And he might say, Dennis, actually, I don't think it's a good fit for ABC. Or he'll say, you know what, this is a good fit. And I'll say, terrific, why don't we get Sang involved? And so I think, and then the whole team starts to come on board. So nobody acts in a singular fashion. So Dr. Weinberg wouldn't see you say, you know what, you're a good fit. I'm gonna talk to that. And then I find out a month later, wait, what's going on? Generally it will start where you talk to your primary, we're all family here, we're all in business together. Me, you, we're all here together. So generally it'll start, I think, with primary care, have that discussion. And then myself, I would say, listen, I think this is a great idea, but I don't know enough about it to tell you any further than I think it would be a good fit. Let's get the expert in, just as if I sent you to a cardiologist. I'm having shortness of breath, I can't really get up a flight of stairs, say, you know what, I think I know what's going on, but I'm gonna send you to somebody who can really manage you much, much closer than I could. Hence, with medical marijuana, it's no different, specialty like any other.
All right, thank you.
I'd like-
I have
Yes.
a clearer picture.
Another question.
This isn't a question, actually. I've been using medical marijuana for 5 years now. I found it very, very effective for the one thing I got it for. I got it for diabetic neuropathy of one leg. And nothing had worked, including a number of injections that went on for years. And finally, somebody recommended the medical marijuana, and I went to a doctor who certified me. And by the time I was taking the third or the fourth pill, the pain went away. And it went away all the time, whenever I took a pill. So I've now been on it for almost 5 years. I take one pill in the morning, one at night. I've never changed the strength. The strength has not changed. Every time I buy it, the box and the bottle I have tell me how much THC and how much CBD are in it, and the amount is always the same. Price changes, but and I have no side effects at all, and that I can figure out. I'm still waiting to get high. I may never.
Thank you so much for
And I
that
just
story.
switched over to Dr. Weinberg because I like to explore some of the other aches and pains I have and see if any of this can help.
That's wonderful. Thank you for that story. And if any audience members have other experience that you'd like to share, please feel free to do that. Thank you. Yeah.
A question.
Yeah, we can hear you.
Okay, since it's not legally federal, how much of your consultations and is covered by Medicare, if any, once you get up medical marijuana is completely.
So I'll repeat the question. That's a great question, which is, if it's federally illegal technically still, is it covered by Medicare, which is a federal program? And if not, how do you pay for it? So this is one of the topics. So how do we answer that? How do you pay for it, and is it covered by insurance?
It's not covered. What I do is, and this isn't just with Medicare, but any kind of insurance, I will give patients a consultation sheet showing what I charge in the consultation, and and I'm being very honest, I won't say anything about medical marijuana on it, but if I see somebody who has inflammatory bowel disease, I'm doing a consultation for that, or chronic pain, or whatever, and then they submit it and may get reimbursed.
You may, or you may not.
So your consultations, if you don't mention medical marijuana, but treating the symptom, that'll be covered by Medicare.
It could be.
The complaint.
It's possible that the doctor visit portion would be covered under your insurance, including Medicare or Medicare Advantage. It's not guaranteed, but it's possible, and that would have to be something that you would submit from Dr. Weinberg's form that he would fill out for you. But the medication portion is not covered by insurance. So Sam, can you talk about that for a second? So there's no insurance company that you know of, and certainly not Medicare or Medicare prescription drug plans that cover medical marijuana.
Right, so there is no consultation fee, but you do have to pay for the medications because of the whole, federal aspect of that. So I think once, there are some bills, in the House and the Senate, once, hopefully they sign those soon so that it can become federally legal, and then it will be covered by the insurances at some point.
So the consensus is it's moving in that direction.
Yeah, absolutely.
Interesting.
It's very expensive.
Yeah. Well, yeah, and as Sang was talking about, it's not cheap to produce, so it can be very expensive.
And how often are they refilling it?
I think it really depends on the person. So again, when someone comes to me for the first time, I will never let you buy like a huge amount of anything. I always start with the smallest of whatever it is, so that we can figure it out. Because if we need to change, we'll change it, but we know I don't want you to have to spend so much money getting something that may or may not do the trick. So we always start with the smallest sizes as possible.
The only problem I had is that I used up to now a different dispensary that doesn't deliver. So I would have to go down and get it every time I needed a new supply. You call the night before or that morning, they have it ready for you, and you pick it up 5 minutes and walk out. In the beginning, I bought only 1 or 2 boxes, but then I had to keep coming back over and over again. So once I knew that it worked, and it worked steadily, and I had no problem with it, I now buy a large amount. They will let me buy 6 boxes, which is enough for 3 months, but then I don't have to go as often. And just recently, I arranged for my daughter, who finally got old enough and sick enough to go and apply for her own job, for her own card, so that when she picks up hers, she can pick up mine and bring it. And now we're switching to Dr. Weinberg's Etienne, so I guess that's going to be arranged through the nurses.
Yeah, I think I'm gonna meet your daughter tomorrow, actually.
Yes, question.
Yes, medical marijuana is something that is different than the marijuana that you can buy in stores, I assume.
Well, it's the same content, because the plant won't change, and you get the same, the cannabinoids that are extracted from the plant are going to be the same, THC, CBD, the minor cannabinoids. I think what the difference is that you don't know where these products are coming from, right? So in the state of New York, the ones in the store, like, in the smoke shops that you see,
Yes.
You don't know where they're coming from, and you don't know how they've been tested. So I think you always question sort of how was this extracted, what is the content, whereas the medical program, again, I'll reiterate that the program is so strict and so stringent that the testing, test every product basically.
what store are you getting marijuana?
No,
from?
I'm not getting marijuana from any store, but I see stores that advertise it.
Yeah, they're not legal.
They're not legal.
No, not the THC.
You know, what's interesting, I had an example of a patient of mine 6 months ago. She's on the west side and she was having chronic pain, and we had this discussion about using medical marijuana. So she says, you know, my grandson from Colorado came and he gave me a couple of gummies. I said, oh, this is gonna be good, you know? So how did it go? She says, well, I took 3 or 4 thinking just like I do with my Advil or Tylenol. She lost her mind. So I'm talking to her, I said, well, can you walk me through the process? Well, I'm having this bad hip. My grandson came, he's 23, he had a whole bunch of these. He gave me a couple, you know, for grandma. And so she goes, I don't want to touch that stuff anymore.
Yeah.
I said, you have to understand. Let me see the bag. She gives me the bag, and there's this rainbow with a fish on it, and like all these stars. I said, what the hell is this? This isn't medical grade. I mean, this is a cartoon. I said, you know, there's 10 milligrams of THC, 10 milligrams of... I said, this is unregulated, not medical, meant for a 23-year-old who wants to have a good night. You know, this wasn't really the way to go. I said, but if I send you to Dr. Weinberg, which I did, and was actually on the east side, it's a different animal. You know, it's being regulated, as you had mentioned, Dr. Molinoff, it was more precise when you go medically speaking. Someone will say, you know, I'm gonna give you 2.5 milligrams of THC with 5 milligrams of CBD. I'm not certain what that means either, but that's why I refer to them. And then I know that it's like going to McDonald's. You know, when you get that mixture every time, it's the same every time. But yeah, a lot of these recreational in New York, I don't believe it's legal to sell this stuff, but that doesn't mean it doesn't happen.
This is a dumb question, but just talk.
No dumb.
I'm an expert at those. Go ahead.
You see a store that says CBC.
CBD.
Are those the licensed ones, or they're still not licensed?
But so what's happened is because adult use is going to go into effect, there are pop-ups all over the state. And the OCM, the Office of Cannabis Management, has basically decided they're not going to arrest them. They're not going to bust them because by the time it would go to court, it's going to be legal and it's not going to be worth it. But that's why I was asking about the stores. There are places all over the city where you can just walk in and get these, and it's not regulated.
I see that, I see that. So that's a danger then,
Yeah.
for people to do that.
Yeah.
It is,
Yeah.
absolutely.
And
It's like the
originally,
Wild West.
When they first started pushing CBD was in all the stores, including the drugstores and all, bottles of it.
Right, like CBD you can get right now anywhere. You can get it off Amazon, you can get it in Walmart, anywhere. Because CBD alone is legal, correct? Just CBD.
Yeah.
So it's the THC out of the plant that is the illegal part.
But the CBD didn't work.
Right, so this is the point. So when you get medical grade cannabis, you're getting highly regulated compounds that are that are clinically proven and they're monitored and they're prescribed and so forth.
Yes.
Now,
Now,
even though the CBD is legal, it's still a narcotic for us in the building.
Oh, really?
Mm-hmm. We still have the, yes.
Interesting.
CBD,
Yeah.
over-the-counter CBD
We
is
still-
considered a controlled substance.
Mhm. We still have to put it in our ear.
so excuse me, I'm a practicing physician.
Taking it themselves is different.
And I was wondering if in my medical prescriptions, can I use that to prescribe the authentic marijuana?
Well, first of all, you have to get registered, so you'd have to take a 4-hour course, which is, fine, and I'm sure you would enjoy it. But you can't write, well, I write prescriptions here. I have to write on my prescription pad for any of the prescriptions or for any of the drugs, the cannabis drugs that are coming in, like through Etane. But you can't write a prescription on your prescription pad for it. It won't fly.
It won't, okay, okay.
And there's certain things that it doesn't work for, that, marijuana doesn't work for.
Right, I think that's an important message that we send to the audience is that while it can be extremely effective for certain things, it might not be effective for those things in certain people.
Yeah.
But it also might not be effective at all for certain
It doesn't
ailments.
work for
So-
arthritis, I've been told, and it doesn't work for my arthritis. I have to use Tylenol for that.
No, we're gonna work on that.
Any other questions?
Just a thing on recreational.
Can you get the mic back there? You gotta talk into the mic, we can't hear you back here.
Just something about recreational marijuana. Is that, other than going back years and smoking marijuana, what, I guess I don't have any understanding of exactly what you're, if you mentioned recreational marijuana from your point of view.
So in terms of the questions around recreational marijuana, and I want to clear that up because in the state of New York, recreational marijuana is legal, correct?
Right now.
And it is legal, but stores can't sell marijuana right now. So you can't walk into some smoke shop and buy pot. That would be illegal right now for them to do. That's coming eventually.
Eventually,
End
they've
of the
been,
year,
yeah.
they said, end of the year.
But by the end of the year,
Around.
perhaps you'll be able to
Yes.
walk down Second Avenue, go into the smoke shop and buy pot.
It's a very complicated process that's going on, seriously, to regulate it. There's a whole thing about, because there's been such an issue for the history since marijuana's been illegal of communities of color that have been disproportionately affected and jailed and had their lives ruined, that they are trying to make sure that the first people who get their licenses to sell recreational marijuana are people who've been in prison or people of color, but it's turning out to be a very onerous, complicated process, and I think that's what's delaying it, because the law went into effect, in March of 2021, I think, so.
Right,
it's
so the
gonna be a
bottom
while.
line is with recreational marijuana is legal in the state of New York. Anyone in this room could have marijuana on them and legally use the product. The question is where you're gonna get it, right? So right now, you can't really legally obtain it recreationally.
You have to break a law.
You have to break a law to
To
get it,
legally use
to
it.
be within the law to use it. Which
You
is-
can also grow it.
So that's true. You can grow it and you can have it in your private residence and use it that way, and that's legal right now.
But people have marijuana dealers.
Yes.
It's true.
We have other questions. Yes, in the back.
Question is, with folks with dementia, can you talk about that? Is that ever, recommended?
Yes, I'm gonna turn to Dennis first, because we always like to defer to our primary care providers when it comes to this management of dementia and behavioral disturbance and psychiatric issues related to dementia with any medication is complicated. It's definitely complicated with cannabis. And as a psychiatric nurse practitioner who has had to deal with this issue, I have a limited array of medication choices that I can use on a person with dementia who has behavioral disturbance or mood or anxiety or hallucinations. And the medications that I have at my disposal, the pharmaceutical medications, are very potent and they have potentially very bad side effects. Now, medical cannabis can be helpful in these situations, but it can also produce the opposite effect, and it can be really challenging to manage. So I want these guys to talk about that, and starting with Dennis.
Yeah, when I have patients of mine that have dementia, generally I'm referring that patient to Dr. Weinberg or using psychotropics in an effort to try to ease some of the behavioral symptoms. And everyone's dementia is different. It's sort of like the autism spectrum in children. It can go from very mild to very severe. And often when I have patients of mine that have aggressive type dementia or behavioral issues that are really becoming hard to hone using psychotropic medication, I'll start to consider medical cannabis. And I do that because a lot of these antipsychotics and a lot of the medications that we're using to alter the chemistry of the brain, they can do so and have very deleterious effects. And oftentimes when we're using one medication, it will give us the opposite effect. Kind of like Brian was saying, can also happen with medical cannabis. When you're dealing with dementia, it's one of the hardest diagnoses to deal with, because when it comes to diabetes, it's a number that I can quantify. Blood pressure is a number, I can measure it, I can see it, I can work with it. Dementia is a completely different animal altogether that you can't see, touch, feel, measure. It's all subjective, and you're trying to change a person. So it becomes very difficult. But yeah, I've seen where we've had patients in the residence here, out in the community, that their behavioral issues, the aggression was very severe. And it has been quelled by using medical cannabis. And not alone, sometimes in combination. Or if I'm using a psychotropic, I can say, you know what, I want to use this, but I don't want to use so much of it. Or I don't want to just knock the person out. And so then I'll talk to Dr. Weinberg to say, hey, here's the situation. And I don't just give him the whole chart and walk away. You know, it is a collaborative discussion. And he'll talk to Chang, and they'll say, why don't we give a little bit of this and of that? Great, let's see how it goes. Dennis had really knocked her out. Well, I tell you what, before pulling back on the cannabis, why don't I pull off on the other psychotropics that are a heck of a lot more dangerous? That if they were to take a whole bottle of this, they wouldn't survive it. But if you took a whole bottle of cannabis, not that I suggest you do either one, but the safety profile is so much more beneficial. So I've had a lot of good responses from using medical cannabis for dementia. But again, it depends on what I'm using it for in dementia. If I'm looking to reverse it, that's a pipe treatment. If I'm looking to stop it, pipe treatment. You know, what I'm looking to do is to manage the symptoms to make the patient, A, be able to live in their apartment any longer. So they can actually have their caregiver remain with them because of behavioral issues.
You know, I think one thing to think about is that there are so many different forms of dementia: multi-infarct dementia, Parkinson's dementia, Alzheimer's. There's so many ways, you know, the end result may seem to be the same, but the processes that are going on, I think, are very different. And cannabis actually, it turns out, there has some neuroprotective effects. CBD seems to really be helpful. I mean, a lot of, like with Alzheimer's, a lot of what's going on is inflammation. And it turns out that CBD can help with the inflammation, and THC as well. You know, without getting into the chemistry of it, but the plaques that develop, it seems that THC can actually help, at least slow down that process. So, and Sang and I were talking about that, and Brian as well, it's problematic because there isn't a huge amount of research, but it seems promising, and we're just starting here and having some promising effects, which is fabulous for all of us to see.
So the research I've seen, and obviously there aren't very many, and the sample sizes are very, very small. So, you know, I couldn't get a definitive answer as far as, you know, what's the progression like, or how does it decrease progression. But knowing how these compounds work in the body, the CBD and the THC and the other cannabinoids, as Dr. Weinberg mentioned, that we know that the CBD works as an anti-inflammatory. It also works as an antioxidant, so it eats up all those like free radicals that are damaging to your cells. And you know, there's some evidence that it does increase neuroplasticity, so that your brain is still making pathways, you know, things like that. So it may delay the progression of dementia, but obviously the others, you know, other things are to be determined because of the studies that haven't been done. I mean, there's a lot of information, but nothing is definitive. But we know a few things that, you know, that can happen, or the things that I mentioned. So we know that it does help to just kind of quell a little bit of that aggression, agitation, and that's the CBD part of that, right? But THC is very helpful too, because it helps to regulate your sleep-wake cycle. You know, it helps with, because I know that, you know, with dementia, there's a lot of like appetite issues as well. So then you start eating better. So I think when you regulate all these other things, you know, you sleep better, then you're getting restorative sleep, and then your body can repair itself a little bit better. So I think it's a combination of a lot of different things that are going on.
So, and with the caveat that it's obviously all on an individual basis. Some people will respond well, some people will not, so we just have to keep that in mind. Yes, sir?
I was just wondering, has there been any advance or beginning of any method of utilization for ophthalmology, for glaucoma, for cataracts? Has cannabis been thought of as useful in that area?
I think people have been using it for glaucoma or to decrease intraocular pressure for a very long time. I'm sure there are some studies, I just don't know of any offhand.
So it's manufactured in a drop form?
No, I don't think so. Is it? I don't
No.
think so.
Not in
I mean,
eye
I
drop.
Eye drops, I don't
Not
think
in
eye
eye
Not in
drops.
eye drop form, but a buccal form, yes.
Yeah.
Thank you.
Okay, do we have any other questions from the audience? Okay, any other last minute comments you guys want to make? This has been an amazing topic, and I've learned a ton here today.
So I gave out some pamphlets, so please look at it. It'll provide you with some information, different ratios, how they come, how it works, and just reach out to me if you have any questions about anything.
I just have last minute for us here on site. Those cards, if there's anyone, especially if you take your own medication, which is important that the nurses are not aware of, and you're on the drug, can you please give us a copy of your card and the certification? I can give you the email, or you can reach out to the nursing supervisor and get it, because we do need to have that on file and upload it onto your electronic medical record. So please.
Yeah, and part of the reason that is, even if you are independently managing your own medication, we from a regulatory perspective, we need that on all of our residents, in part because of if there's ever an emergency and we have to send you to the emergency department, we need to be able to send with you an updated record of what medications you're taking and why. So that's part of why we have to do that. Okay. So if you have further follow-up questions, you can talk to the clinical team here. Dennis, Dr. Weinberg, Sang are all available to us as part of our integrated team of clinicians working with this issue. Try to be patient with us as we know there's a lot of interest in this topic, and we will work with you as quickly as we can to get the process rolling. It is a process. It's not, if you're new to this and you wanted to get enrolled in sort of the program, it might take a little while for us to get through that process, but we will make sure that happens. Thank you, everybody.
Thank you. Nice to meet you, Dr. Sam.
Thanks. Yeah, I read. There's two people that. Should I